Hello and welcome to Parcon 2021. My name is Gary Shaughnessy and I'm the Chair of Parkinson's UK. Thank you particularly for joining this session where we'll be looking into a crystal ball to look at what the future of Parkinson's treatments might look like. I'm delighted to be joined by Roger Barker and Dr. Rowan, who will be setting out their views and their vision. In the meantime, just a quick introduction on both of them. Roger Barker is Professor of Clinical Neuroscience at the University of Cambridge, an honorary consultant in neurology at Addenbrooke's Hospital. Earlier in his career, when he was a medical student, he actually wrote to David Attenborough to film together a TV series. And I don't know why David Attenborough chose not to do so, but otherwise he would have a very different history. Dr. Rowan is Associate Director of the UK Parkinson's Excellence Network, and that brings together health and social care professionals to transform care for people affected by Parkinson's. When she's not caring for people affected by Parkinson's, she's helping her mother care for two 50-year-old tortoises who are called Pliny and Sato, apparently, and are escape artists as well, which I think is remarkable for a tortoise. I'm really looking forward to hearing what their thoughts are on the future and what it may mean in terms of treatments and care. Before we dive into the presentations and the discussion, though, just a few notes for those of you who are joining us live. We'd love to hear from you, and please do share your thoughts, your reflections and your comments and any questions that you've got in the chat. And after the session, the speakers will be live to answer your questions. And you can raise a question using the Ask a Question button, as well as by putting something in the chat. But we'll talk through that later on. Okay, I think that's all the preliminaries. I'd like to hand over first of all to Roger, who will be kicking us off by sharing his hopes for what treatment will look like in that not too distant future, hopefully. Roger, over to you.
Thanks very much, Gary. Thanks very much for inviting me to do this. It's obviously a bit daunting discussing what I think will happen in the next 10 years. And I think to begin with, it's probably useful just to have a quick reflection on the last 10 years and see the direction of travel. So I would say there's been a huge sea change in the way we perceive Parkinson's disease in the last 10 years, which I think is going to play out in a major way therapeutically going forward. And what do I think those major changes are? Well, I would think the first is the concept of Parkinson's disease as a constellation of different types of disease. So I don't think there's anything fundamentally different between different people with Parkinson's in terms of what's necessarily going wrong in the brain, in the body. But I think this idea that there are different types of Parkinson's disease is going to be important. So there are some people who do seem to do very well with the condition. Sadly, there are some who do less well. The question is, well, why is that? And can we start to stratify people into different types of Parkinson's disease, which not only has impact for now, so we can tell people what the future holds with a bit more confidence and perhaps better understand what goes wrong in certain types of Parkinson's disease, but I think it's going to have an impact on trials. So I think taking everybody, lumping them into one trial and saying, let's chuck a therapy at them and see what happens is not going to be the way forward. And this has clearly been the success of cancer in my 35 years as a sort of doctor, really. When I started cancer, breast cancer, for example, was one disease treated in one way. Now it's several different diseases treated in different ways. So I think this idea that we can see Parkinson's disease as related but distinct types of disease is going to mean that we're going to start stratifying patients into different groups for different trials. And that, I think, has become more prevalent as a view. I think there's work that's pointing the way in that direction, and that's been coming over the last 10 years. And whilst it's been rather descriptive to date, now we have the capacity with these new technologies of growing cells from people by taking bits of skin and turning them into nerve cells. We can start to understand what might be going wrong specifically in different types of disease, which will then impact on the trials. So I think one vision I have for the future is that we're going to be a bit more selective in who we take into certain arms of certain trials. That's not to say we're going to exclude people. I would hate to think that people think, I've got Parkinson's, I'm not going to be suitable for any trial. I think there's just going to be a bit more selection of what trial suits which person best. So I think for me, that's going to be one of the major changes, that we're going to start to see stratified trials. And that has been, as I say, prevalent over the last 10 years in terms of a concept. I think linked to that is this idea that what are we going to treat people with, and what are we targeting? Well, I think it's fair to say that in the sort of preclinical space, things which are done in the lab, there are no shortage of targets. So it always amuses me in some ways at medical conferences that people will stand up and say the problem in Parkinson's is it's to do with the powerhouse of the cell, the mitochondria. And that's what it's all about. They sit down, next person stands up and says the problem in Parkinson's is related to the way you get rid of proteins inside cells, these things called lysosomes and the autophagy pathway. They sit down, next person stands up and says, well, I think it's all to do with the fact that actually when your cells get stressed, they stop producing protein. It's the unfolded protein response. Well, each of them claims that that is the primary pathway. It could conceivably be that actually all three of them are involved, and that's much more likely to be the case than just one. So I think this idea of selecting a particular pathway, which may be relevant for certain types of disease, I personally think we need to move slightly away from that. So I'm quite a fan of this sort of polypill approach. And the reason why I'm quite interested in this is an idea that we target several pathways and that all of them are slightly abnormal in diseases, and they may be more abnormal in certain types of Parkinson's than others, is if you look at some of the successes in medicine over the last 20, 30 years. So in my lifetime, one of the great therapeutic successes has been HIV. So when I qualified in the mid-80s, if you had HIV and got AIDS, you were dead. I mean, that was it. There was no treatment. And then over the years, what's happened is people have slowly worked out what goes wrong in the pathway, the different parts of the pathway, and then they've targeted each bit. So they've given different therapies. So you have combination therapies. And that combination therapy nowadays has transformed the future for people with AIDS and HIV. In essence, many of them are cured by that combination. And the same is true on how we treat certain types of infection, like TB, how we treat heart failure, how we treat high blood pressure, how we treat stroke. So I think that going forward, this idea that we're trying to select specific targets, whilst it's useful to try and understand what goes wrong in Parkinson's, I think we should be thinking more about, can we do combination therapies to try and help all of these pathways? Because if all of them are a little bit wrong and I can make all of them a little bit better, not completely normal, but a little bit better, we're probably going to make a huge difference. And it's that, I think, which is another important concept. So if we believe that Parkinson's disease, by the time it presents, has already been chugging away there in the background for 10 or 15 years, then most people with Parkinson's then have it for another 15, 20 years. So this is a disease that lasts about 30, 35 years. And by the end of that, obviously, people can be quite disabled by it. Now, if you slowed it down by 50%, so you actually change it from a condition that lasted for 35 years to a condition that lasted 70 years, I don't think we need to worry too much about it, because something else will come along and get you by the time you're starting to develop more problems with this condition. So I think a cure is a wonderful thing to aspire to, but actually a significant impact on slowing it down would have a major impact on treating Parkinson's. So in this country, for example, with Alzheimer's disease, which is obviously a very prevalent disease, more prevalent than Parkinson's, if you could delay the onset by 10 years, it would have absolutely massive impact on healthcare, care homes, and everything else. So whilst we want a cure, actually slowing down the disease by a relatively modest amount, I would say, could have a major impact on it. So I think my vision is we will stratify patients. So we'll have subtypes of patients, and then we will give them multiple therapies, is the way I'm thinking about this, but there may be more of one type of therapy for one type of patient. So I think personalized medicine, polypills, and then linked to this, I think, is then how do we know whether we've made any difference? So this is actually quite a difficult question. So one of the problems with all diseases of the brain is knowing whether you've made an impact on slowing down the disease or just made the patient a little bit symptomatic better. Their symptoms are less obvious, or everyone just feels rather good about it, so everyone feels better, but you haven't fundamentally changed the disease process. And that's different for brain diseases, say, to liver disease or kidney disease. If I have a therapy which I think slows down kidney failure, I can do blood tests. I could even take a biopsy of the kidney. I can scan the kidneys very easily. It's all very easy to work out whether I've actually made any difference at all. The trouble with Parkinson's disease, if you like, is that most of it is in the brain. It's not all in the brain, but most of it's in the brain. So how do I measure that? Well, that's not easy because it's obviously contained in a hard box, which is your skull, and I don't have much easy access to it. So that's difficult. Secondly, it doesn't change very much. As I've said, it progresses, if you like, over a quarter of a century, 30, 35 years. So there's not much change every month. I mean, over months it adds up, but individual months. So how do I know whether I've actually made any difference at all? So I think there are two ways in which you can tackle this problem. One is you can try and get more specific. And I'm not actually a fan of this, which probably you don't want to hear, but things like collecting lots of electronic information on people. So lots of these apps, which people quite like, measuring motor changes, getting people to do tests online, which I'm a great fan of, but collecting lots and lots of detailed information on people and then trying to analyze that, see whether actually there's been a change in the trajectory of patients over time. So for example, if you have a Fitbit, as I do, and you're completely obsessed about it, as I am, then what you can do is you can measure what you're doing in a 6-month, 1-year period. You then start someone on this combination of drugs, and then you look over the next 6 months to a year and you say, I don't really care how you're feeling. I can look at your electronic movements as recorded electronically, and see whether it's made a difference. Now, this gives you a sort of, if you like, an objective measure, because it doesn't really matter what the patient thinks. It doesn't really matter what the investigator thinks, because it's being collected remotely. It's being collected in an objective way, assuming that the patient's wearing it, it hasn't given it to somebody else or put it on the side. But then the problem with it is, well, what does that mean? So I say to Gary, well, thanks for coming into my trial. You're actually miles better because your Fitbit has told me that you're actually shaking a little bit less and you're moving a lot more than you were 12 months ago. And Gary then says, yeah, but I feel rubbish on this trial. I just don't feel very well. So, collecting that information is helpful, but ultimately it's what the patient feels and experiences that's going to be important. So I think this has two implications for how we're going to start to measure the efficacy of trials. We are going to have some objective measure to show that we've slowed down the disease process somehow, whether that be a blood test or through scanning. But I actually think we should do longer trials, so trials that run for longer periods of time, and we look for critical patient-related outcomes and milestones, because I think these are much more important. So, the point at which people start to have problems with freezing of gait, getting stuck to the spot, the time when they start having problems perhaps with their blood pressure. Now, not everyone ends up here, and people get to it at different times, but actually I think using these milestones and patient-related outcomes will give us much more confidence whether we've made a difference. Now, if I only do this over a 3 to 6 month period with a trial, I'm never going to see anything. So actually, I think we need to rethink trials and think, actually, we're going to keep people in trials for 2, 3, 4 years to see whether we make any difference with these medications. Now, I can hear you then saying, well, that's great, Roger, I love that idea, but one of us is not going to be on any active treatment, because all trials have active treatments, and some of them don't have active treatments. They have placebo, so I don't want to sit in the placebo arm for 4 years and get no active treatment. Well, Tom Fultony and Camille Carroll have just received funding from the Edward J. Safra Foundation to set up a sort of, to try and put together a platform for clinical trials, which is called MAMS, multi-arm, multi-stage trial. So the idea of this is you actually set up many arms in a trial, testing many different therapies. Now, you may have a placebo in that, or you may just have one treatment, which is everybody on as a putative disease-modifying therapy, and then you have other arms with different agents in it. And then what you do is you run all these in parallel, and the idea of it is you say, well, actually, after a while, we do an interim analysis. One of these arms, the drug or intervention, the physio, the gene therapy isn't making any difference, so we're going to stop that arm and reallocate those patients to another therapeutic arm. And so this, I think, is a very exciting idea. So this has been used before in cancer. So prostate cancer in this country was the subject of such a trial called the Stampede trial. And over the last, I can't remember how many years, 15, 20 years, that has totally changed the treatment of prostate cancer in the UK from when that trial began. So what is now, if you like, their control arm, their placebo arm, incorporates all of the modifications and improvements in therapy that have come through the previous arms of that Stampede study. So I think looking to the future, I think we're going to have a different landscape for trying to treat Parkinson's disease. We're going to have different groups of patients, which to some extent will be classified around the different types. We're going to have multiple arms running with multiple therapies, I would say combination therapies, with outcomes which are much more meaningful in terms of milestones, which we can then use to have much more confidence that we're slowing down the disease. The final thing I would just say in the last couple of minutes is that the other area which I think is also going to change a lot in the next 10 years, obviously I'm very biased in this, is the use of agents, better agents to treat the dopamine aspects of Parkinson's disease. So disease modification is obviously to stop the disease. Dopamine medications are obviously the mainstay of therapy, Madapar, Cinemet, etc. Now, I think we're just sitting on the cusp of a whole series of trials which are going to start looking at putting new cells into the brains of people with Parkinson's around dopamine replacement. This has been around for 25, 30 years using other types of cells, but we now have the technologies to turn stem cell into dopamine cells. Our own trial with the group in Lund in Sweden is due to start next year. We work closely with the company Novo Nordisk, who are planning to do a subsequent trial using similar technology. Blue Rock Therapeutics in the United States have started their trial. They're owned by Bayer. They're planning to do more trials with this therapy. Fujifilm, Cellular Dynamics, also in the States, are starting to plan their trials. The group in Japan have started their trials 2 years ago. So this is a whole area that's likely to really take off in the next 5 or 10 years. And if it proves to be effective, then this has huge potential, not to slow down the disease, but to radically change how we treat it. So in theory, if we can put back 100, 200,000 dopamine cells to replace the dopamine cells which have died as part of the disease process, then in theory, we could treat people when they first present with their Parkinson's. We put back 100 to 200,000 dopamine cells. They don't need to take any drugs to replace the dopamine because we've done that for them. And then they don't need any drugs because we fix that bit of the brain. Some of the complications from taking the drugs don't happen because you're not taking the drugs. And so whilst we haven't slowed down the disease, we have dramatically changed the natural history of treated Parkinson's disease. So this has the potential to actually make everything we do in clinic now, therapeutically in terms of drugs, redundant. So all of the drugs become redundant. Amantadine to treat dyskinesias becomes redundant. Deep brain stimulation becomes redundant. Now, I'm not saying that will necessarily happen for everybody, but there is a great sort of potential that we could change the symptomatic treatment of Parkinson's disease. And there are gene therapies, the idea you inject a gene into the brain that makes dopamine that could do the same as the cell-based therapies. So I think whilst I have great sort of hopes that we will change the landscape for doing disease-modifying therapy trials and how we measure that, how we assess it, how we set up those trials, and how we target the pathways with drugs, I also think there's a revolution coming on better ways to deliver dopamine. And that's not just with cells. There are other forms that come along. There's an under the skin form of L-DOPA, which is looking very promising. So I think there's a revolution also coming in better ways to deliver dopamine to help people with Parkinson's disease. So it's a very exciting time. The next 10 years, I think, is going to radically change how we see Parkinson's, how we treat it, with the hope that at the end of this, we could end up with a combination of these two. So Gary presents in 2027. I stick some new cells in his head. I stick him on a poly pill. Thank you very much. I don't need to see you again. Get on and run the London Marathon.
That last bit sounds perfect, Roger. Thank you very much. And fascinating and really hopeful as well, which is great to hear. I mean, I love the sort of the focus on the individuality, recognizing the difference of how both people actually are and how they could be treated. And it almost comes to end up with not trials where you think about not does it work, but who does it work for and how does it work best is the way I'm hearing you a bit, which is fascinating to hear. And we'll get into more conversation about that later on. So thank you. And it's a neat segue, I think, into talking to Rowan. Hopefully you'll build on Roger's talk by discussing how care and services may look in the future, and a future that, as Roger says, could be very different, and how that will be driven and shaped by professionals. So over to you, Rowan.
Thanks so much, Gary. And Roger, it was really interesting listening to you talk. And my background actually was in oncology. I remember being an oncology registrar and recruiting people to the Stampede trial. So it's really interesting that you see kind of Parkinson's going in that direction. And I can see lots of things that we've learned in oncology translating really well into Parkinson's too. So thank you. I have a presentation, so I will now share my screen. Can I just check that you can see that? Great, thank you. And just thank you again for inviting me to talk today. It's an absolute pleasure, and I really look forward to the live session. Here's my take on what treatment in its broadest sense will look like in the future. And as Gary said, I'm going to be focusing more on how care will be delivered, what services will look like, how it will feel to the person with Parkinson's. I'm going to start with a vision for the future, and it's not that far into the future. My vision is everyone with Parkinson's living in the UK has access to best practice, person-centred, multidisciplinary care. This means getting the right care from the right expert professionals at the right time, and I'm going to come onto that more in a second. Care is centred around what matters to the person, it's coordinated by an expert multidisciplinary team, and there's seamless communication between everyone involved, the person with Parkinson's, their relatives and loved ones, and the clinicians and care professionals that are looking after them. I can hear what you're thinking, or I know what you're thinking, and you might be thinking, well, that's not particularly groundbreaking. That's not groundbreaking stuff. It sounds simple. But if it was that easy, it would be happening everywhere all the time. And unfortunately, at the moment, it's not. What will this mean in practice? So by right care, I mean personalised care plans that are anticipatory and goal-focused. So it's not about someone having a fall and then being admitted to hospital and then people thinking about, how could we help this person? How could we reduce their risk of falls? What kind of protection might they need to be on to help protect their bones? It's about thinking ahead and really anticipating the symptoms that might come up, how we might prevent crises from happening. It's also about shared decision-making, and for that, people need to be equipped with the right information in a format that's accessible for them to make the decisions that are most suited to them and that will help them get what they want to out of their lives. I think there's a big element around equal access to treatments and clinical trials. At the moment, we know there's huge variation, so what you might be able to access in Cumbria or Northern Ireland is very different to what you might be able to access from Cambridge, for example, where Roger's based. And then all of this needs to be underpinned by the right technology that enables seamless communication, so that the person with Parkinson's isn't telling their story over and over again to every single person who's part of their care team, repeating themselves, explaining the treatment they're on. That should all happen seamlessly in the background so that the person can focus on what they want to discuss. It's also about having the right expert professionals. And I think for me, this means a core multidisciplinary team who really understand Parkinson's and have expertise in Parkinson's. That's doctors, nurses, physios, occupational therapists, speech and language therapists, those core clinicians who with the right training can really help someone with Parkinson's. We know that Parkinson's is incredibly complex. I'm sure already at Parcon you've heard about the multitude of symptoms, more than 40 symptoms, motor and non-motor, often the non-motor being more bothersome than the motor. And those professionals treating the person with Parkinson's need the right knowledge and skills to actually make good decisions and support the person. And the right expert professionals is also about smooth pathways into relevant services. So, for example, mental health services, sleep services, pain services, continence services, the services that will really help that person manage their symptoms and live well. And then finally, it's about care being there at the right time. So firstly, early diagnosis. We hear time and time again when we talk to people who've been diagnosed with Parkinson's, they look back and they say, actually, I've had symptoms for many years now, I can see that. And we really want to bring down that time between noticing symptoms or even changes happening in the brain and the person receiving the diagnosis, so that as soon as possible, they can be started on the really effective and interesting treatments that Roger has just been talking about. Again, due to the complexity of the Parkinson's, people, I think, need regular comprehensive reviews. And the reason, and they should be as required, but at least annually, one of the people with Parkinson's in one of our steering groups calls these reviews her annual MOT. And the reason that this is important is because Parkinson's is so complex that people often don't know what's their Parkinson's and what's not. And actually having that comprehensive review, discussing symptoms as they emerge, discussing new needs, and just being guided about what could be related to the Parkinson's. Is there anything that can be done about it? And finally, under right time, it's about them having a mechanism for responding rapidly to significant change in symptoms or needs. And that should be arranged so that the person with Parkinson's at the center of the care can trigger an assessment themselves. They're not waiting for 6 months for their next review, for example, to be able to discuss things that have emerged. As I said, it doesn't sound groundbreaking, but it's not happening everywhere, and it should be. And there are lots of changes and innovations happening now and kind of on the horizon that will help make this vision a reality. First, new health and social care structures. Many of you may be kind of sick of reorganizations in the NHS. We go through them every kind of, well, it feels like every few years at the moment. But actually, the new reorganization that's happening at the moment is about improved collaboration and integration of services. And I do believe that will be really helpful for Parkinson's services, because Parkinson's does rely on so many different services. It's integration both within the NHS, but also better integration with social care, universities, and the voluntary sector, so that everyone is on the same page and working towards better services. There's also, I think, going to be an accelerated bench-to-bedside pathway. We've learned lots of lessons from the coronavirus vaccine development, and actually really brought down that time from ideas in the lab turning into actual treatments and then rolling them out at vast scale. And I'm really excited about working even more closely with my research colleagues to bring novel treatments into practice, into everyday practice, very quickly, and rolling them out to everyone. Third, there's technology for diagnosis and monitoring. I think this has to be used in the right way, and Roger's touched on this a little bit already. But there is a role for me for algorithm-assisted diagnosis and clinical decision-making. And particularly, we know that can help in assessing someone with Parkinson's who may have lots of visual symptoms, and there's lots of visual cues that AI is starting to have the capacity to recognise. I also think we'll get to a place where we have more intelligent treatments relating to better technology. So, for example, implanting sensors, intelligent sensors at the same time as having your deep brain stimulation surgery that can make adjustments in real time to your stimulation, so that you're really benefiting from what's happening right now, rather than waiting time and then making those adjustments later in clinic. Fourth, it's about new prescriptions. And I don't mean sort of drug prescriptions. I mean interesting technology and social prescriptions that might help people with Parkinson's. So the photo here is someone who's wearing a new pair of glasses developed by Strong. They're essentially virtual reality glasses that project visual cues onto the visual field to help with freezing and to help someone moving. And I think I love to see these becoming part of kind of the suite of prescriptions that are available to clinicians managing people with Parkinson's. Social prescriptions, I think there's lots of chatter about these, and I don't necessarily think this has to be something that the doctor has to prescribe. I think it's about better signposting in clinic, for example, to other services that can really help someone with Parkinson's. And Parkinson's Connect, the sort of flagship program, information and support program at Parkinson's UK is one element of that. But it's also about signposting to, for example, exercise classes that are targeted at people with Parkinson's, so that they're really they're helping people do the exercises that will really help their Parkinson's rather than just being a generic class. And then finally, I want to talk about the electronic patient record. I think there are obviously big changes happening in this space, and I think, well, the dream is one record that is shared across health and social care and jointly owned by the person at the centre of it. I'd love to see this happen in the next few years. I think it does take time to get these into practice, but we are making changes. There are changes already happening going in that direction, and the sooner the better. Next, I'm just going to talk a little bit about the UK Parkinson's Excellence Network and our role in making some of this happen. So the Excellence Network is a network of people with a shared vision, and that is, together we will improve Parkinson's care across the UK, building and supporting a multidisciplinary workforce with the data, learning opportunities and tools they need to thrive in an ever-evolving health and social care system. It's not just a network for specialist clinicians, although we do have a lot of clinicians with Parkinson's in their job title, Parkinson's nurses, neurologists, care of the elderly, consultants with specialising in movement disorders. It's also a network for people affected by Parkinson's, both people with the condition, but their relatives and loved ones, and other clinicians or care staff who don't necessarily specialise in Parkinson's, but for whom it's really important that they have a really good understanding of the condition. GPs, for example, care staff, emergency department doctors. And then our team at Parkinson's UK wraps around all of those individuals, and we're really here to drive forward the changes that they want to make happen in the world of Parkinson's services. I'm going to finish by just talking through our 4 priority programs, and these are big multi-year programs with big ambitions. The first is around the Parkinson's workforce fit for now and the future. And so much of Parkinson's care is about the people looking after you. And we know that there's a crisis of workforce at the moment, but we're excited to get other people excited about specialising in Parkinson's, moving into the field. This program is also about kind of considering caseloads, evening up caseloads, and really working towards better succession planning within the NHS. We know that a lot of Parkinson's nurses, for example, are due to retire in the next few years, and we want to be ready for that and have the new generation of Parkinson's specialists ready to take up the reins. Second, person-centred multidisciplinary care. This is really about delivering the vision that I shared at the very beginning of this talk. And we're excited soon to be going out to recruit 8 accelerator sites to make hopefully huge progress towards this vision. Third is better bone health. And this is one element of better preventative care. We know that people with Parkinson's have an increased risk of osteoporosis. we know also that they have an increased risk of falling. But it's surprising how many professionals working in the field of Parkinson's don't consider bone protection when they're assessing their patients. And we really want to get that into standard practice, and also and hopefully reduce the risk of fractures for people with Parkinson's that can be devastating when they happen. That shouldn't happen. We can do things to prevent that, and that program is to really try and get to grips with that. And finally, cracking, get it on time. This is around medication management, and it's a bit like painting the fourth bridge. We go round and round this, and there's lots of education and training that's happened within the charity over the last decade or so. But we're starting to think about what factors can really help people get their medication on time that aren't reliant on training and education, and some novel delivery mechanisms, for example, that Roger was talking about, so that it's not reliant on people remembering to, for example, take their pills, or for health and social care staff to give that medication at the right time. I'm going to finish there, but just to say that I'm hugely excited about delivering some of these elements, and I don't see that they're very far away. As I said, lots of them are happening in pockets in different places of the UK, and it's the role of the Excellence Network to get all of these elements of good practice happening everywhere, all of the time.
Thanks, Rowan. That's really, really impressive and very helpful. I mean, I have to say, when I combine the two, this vision of treatments that are personalised, recognise the individuals and recognise the differences between the way that both the condition can progress, but how it actually exists for individuals today, and a treatment and care process that is much more holistic, utilises technology in a much more outcome-based way. Both of those are very powerful and work well together. I'm sure a lot of people listening in will be saying the obvious question, which we'll come on to in a second, which is, when and how quickly can we make this thing move forward? But I think it's very interesting for me how the two areas that you both talk about start to dovetail. So before we open up to the live Q&A, I've just got a few questions which will hopefully pick up on that, which we can maybe talk about. That's the first question I wanted to ask both of you, actually, which is, how do you see those two areas coming together, both the holistic care and support and the individualization of treatment and treatment development? And because clearly the end game is very attractive, but how long it takes to get there is a critical issue. So maybe, Rowan, do you want to answer first, and then we can ask Roger to pick up?
Sure. So I think that's exactly it. We need the two together. That you can't, one without the other is not enough. I think a lot of what Roger and I have been talking about, a lot of the things that Roger and I have been talking about, are within reach, not far off, a couple of years, not even that. I would like to see a lot of the things I've discussed delivered within Parkinson's UK's current strategy, which lasts from up to 2024. So, not far off, but there's a lot of work to be done. And there's a huge group of people we need to bring along with us. I think the key for me is where the interesting link is how I and the health service and government can be ready to take advantage and capitalize on the innovations and research developments that Roger is talking about. And I think one element that will really help with that is actually the environment we live in. We have to be able to make the economic case for new treatments, new ways of delivering care. And I see my role as helping to make that case. What is the societal benefit? What's the economic benefit? There will clearly be a health benefit, a care benefit for the individual, but we need to be able to make the case for society and the economy in order to get things rapidly translated into routine clinical practice.
Thanks, Rowan. Roger, your thoughts?
Yeah, well, I mean, I very much echo Rowan's thoughts. I suppose my vision would be that a lot of these innovation that Rowan talks about actually become standard of care. So in this sort of multi-arm, multi-stage trial, everybody has standard of care, which they're part of a multidisciplinary team. All of these sort of non-pharmacological therapies are offered and routinely given to patients. The care of the patient as a whole, as opposed to just around one aspect of it, is all integrated into looking after them. And so that is taken as said. And I think we should congratulate ourselves in some way on this, because when I talk to my American colleagues about trials, standard of care in the States is very, very different to what we talk about standard of care in the UK. I mean, everyone in the UK can get the drugs for Parkinson's, most of them. That's not always the case in other countries. So I suppose part of the challenge will be how much we can integrate that into a standard of care so that it's routine for everyone to have that, which is obviously a challenge, especially with the health service at the moment. And I suppose the other challenge for me is integration, because one of the difficulties I always think in all of these different interesting, exciting strands is how you can bring them all together. So how do we get the groups working on patient-related outcomes to feed into clinical trials? How do we get people who are deciding on what to put into a clinical trial to talk to other people putting things into clinical trials and integrate clinical trials? How do we better design trials and such like? So in that sense, I think, this initiative, which I mentioned earlier, which Tom Fulton and Camille Carroll are running, is a very exciting one, because it's sort of trying to integrate all those elements together to set up something which will benefit the entire Parkinson's community in the United Kingdom. And so, I feel very optimistic about it. I think it is challenging, as Rowan says, because the National Health Service at the moment is in a difficult time because of COVID. And the key thing is to keep the case going for why this is so important for people with Parkinson's disease. And it's also getting people to understand it's not short-term cost savings. So one of the difficulties, for example, with deep brain stimulation used to be everyone said, oh, goodness me, that costs an absolute fortune, that device. We can't be affording that. But actually, that's because as a lump sum, it is a lot of money. But if you factor that in against all the money you save from drugs, keeping people in employment, all of this type of thing, it's actually a massive saving. So I think it's trying to get this bigger integrated picture that's going to be critical for the delivery of all of this. And I think we're in a good place to do it, but it's going to require quite a lot of persuading and persistence.
Brilliant. You both, I think, recognised and focused on the individual. And, when you talked, Rowan, about experts and bringing experts together, I guess from my perspective, that includes the person with Parkinson's as an expert in their own right, an expert on how they feel and how they perceive changes and the actions they can take. I'm interested. My perception is that, the mindset that someone applies to the way they deal with their condition can make an impact. How do you see that linking in so that we work on how people approach their treatment and their support in a way that helps improve the outcomes, as opposed to the world that we've been in, which is treatments designed and then given to the patient? How do you see the individual's responsibility for realising the best outcome possible? Roger.
Well, I think it's easier for some people than others. So my practice is always to get the patient to own their illness. It's for them to take charge of it and decide how best they can manage it with our help. So I think it's about ownership and being proactive about it. And there was a point Rowan, I think, made very persuasively, was trying to preempt things rather than wait for things to happen and then decide what we're going to do about it after it's happened. So I think it's very important that we take every person as an individual. We obviously have to do some generalizations, otherwise a trial of 100 people becomes 100 trials of one person, which becomes very difficult to manage. But I think nevertheless, the advantage of these sort of multi-arm, multi-stage studies is you could say, well, actually Gary's worry or major interest, if you like, in his Parkinson's disease is X. Claire, for example, it would be Y, and we say those are the key milestones for you. we can work around that in a trial to make them meaningful for you if we have a therapy to do that. So I think personalization is a great thing. I think we are going to have to be a little bit more general than that. Otherwise, it does become very difficult to manage. But I think getting the patient input, and this is where I think the patient-related outcomes have become so important, because we spend a lot of time collecting bits of information, and we always get trapped in this vicious circle. So we do the Unified Parkinson's Rating Scale, and we say, well, what does that really mean? We don't know, but we collect it. So then you say, we won't do it. And then you go to regulatory agency, and they say, what are you going to do? And he's going to go, oh, patient-related outcomes. They say, have they been validated? No. Perhaps you should do the UPDRS. You go, okay, well, we use the Unified Parkinson. And so you just keep going round in the same circle. So we have to sort of grasp it and say, right, as a community, we're going to change how we do trials. We're going to change how we assess them. We're going to get the patients to be an active and ambassador for that. So they're going to be the ones that are actually going to lead on this. And the medical profession as such will just come alongside and help, but it's actually not being led by us.
And Rowan, can I ask the same question of you, but just to add a bit of context to this, I lived in Switzerland for 3 years of the first 3 years after being diagnosed, and the approach there is a little bit more to care is driven more by what does the patient believe their need is. But there's an obvious economic challenge that comes with that, because the patient therefore can end up driving costs, and that doesn't fit with a free at the point of delivery model. So what's your perception on that?
So I agree with Roger in the sense that people want to feel in control of their condition. They don't want to feel that it's controlling them. And the more that they're able to express, what they're hoping to do, what do they want to get out of the treatment they're receiving? And the more that they're listened to on that front, I think will put them into a positive mindset, help them to feel empowered, and actually help them to manage their condition better. I do think that it's much easier to be in a positive mindset and actually manage your Parkinson's well if the health service and health and care service around you is running well. When you're battling to get an appointment, can't communicate with your clinician, telling your story over and over again, waiting for hours in A&E to tell someone who knows nothing about Parkinson's why you've fallen over, that does not put you into a positive mindset. That does not help you as the person with Parkinson's manage your condition. So I would like, and there's challenges everywhere, but I see our role, and I'd love to see the health service smoothing out the pathway as much as possible. So we're taking all those kind of external factors that really bother people with Parkinson's away. So all they have to focus on is what they want, how to manage their Parkinson's, how to live well with it, and we're taking away all the other noise. And then they'll be in a better mindset, and actually that will I think will result in better outcomes even without drugs.
Thanks, Rowan. And I mean, both of you have given a very positive outlook, although recognise the challenges of getting there. I have to say the timescales that you talked about, give me some cause for encouragement. But what do you think, if we had to do one thing to speed up the process of translating all the positive ideas into reality, is there anything in particular that we really need to make sure we focus on, do you think? Rowan, maybe you first.
I think speeding it up, the best answer I have is actually bringing the people with Parkinson's much closer to the innovators, the entrepreneurs, the researchers. They have lots of ideas themselves, and they're the reason that people working on the other side are doing what they do. So actually creating opportunities for cross-pollination of ideas and really encouraging each other, bringing, that's one thing. Like I said, I also think, we need to be better at explaining why new treatments, novel models of care will be better overall. Why, for example, investing in X will result in Y cost reductions at the end. So I've kind of gabbled a little bit, but I think it's about bringing people with Parkinson's together with the innovators, the entrepreneurs, the researchers, the clinicians, and designing together those, the policymakers, designing together what changes are most beneficial and how to bring them into practice as soon as possible.
Thanks, Rowan. Really clear. Roger?
Well, I would say there are two things, really. One is sign up. Patients sign up for research, sign up for trials, because there is always a slight problem with getting enough people recruited to trials. Partly that's because the way we set up trials. But I think getting involved with research and getting involved with trials is very important from the patient side. I think the other thing is, and you don't often hear this, COVID has done some very good things for us. And what it has done, one is the point that Rowan made, that the government couldn't go through the usual, or the regulators couldn't go through the usual 3, 5, 10 years to sort out a vaccine for COVID. It had to be sorted out in a few months. So I think learning lessons from the regulatory point of view, that we can speed things through so we can get things quicker into trials, because I think this sort of slightly paternalistic view we have that we're protecting people from these rather ghastly sort of trials and such like. I think people are much happier to take risks. So I think that's been one. I think the other is COVID taught us how to do a lot more at a distance, as we are doing now, in terms of assessing people, getting information in from patients, running trials remotely. So I think capitalizing on the speed with which we can get regulation sorted out, and the way in which we can be flexible about recruiting, following and assessing patients, I think is something we should really capitalize on, whilst ensuring that everybody signs up for research and trials.
Thanks, Roger. Sign up.
And the Excellence Network. And sign up to the Excellence Network.
And sign up to the Excellence Network. So two clear plugs. Thank you both for what I think has been both fascinating and I think really hopeful view of what the future is, but with a clear message about the challenge of making it a reality, and the need for all of us to engage in making the move from a possibility to actual delivery in reality. I look forward to seeing what questions we've now got from all the attendees and the live Q&A session. Thank you very much. Welcome back, and I've got Roger and Rowan here again for the Q&A session, and we've got already loads of questions in the question box, so I'll get right into it. Firstly, Roger, we're going to take you from the future to the past. So a few years back, I think I remember Roger Barker saying if he was a betting man, his money would be on alpha-synuclein as the most exciting research area. Do you stand by that? And where does that research stand at the moment, and how would a person with Parkinson's be able to benefit from the findings?
Yeah, I think I stand by it. It might be different to what politicians would say, but I mean, alpha-synuclein clearly lies at the heart of what goes wrong in Parkinson's disease, because we know that from genetic studies and we know from pathology. So alpha-synuclein misbehaves, and its misbehavior leads to Parkinson's disease in some way. Therefore, the money has to be on getting to alpha-synuclein and doing something with it. I think over the last 5 years, that has really taken shape in the form of actually antibody immune therapies to try and get rid of alpha-synuclein. But I think that whilst those therapies are still in trial, we haven't yet had any evidence that they really work. But I still think that's very much where energy should be directed. The problem will be trying to get it to target the right form of alpha-synuclein in the right cells over a period of time that makes a difference to patients' disease course.
Okay, thanks, Roger. Question for both of you, and I'll ask Rowan first. This one's from Anne. How will the speed of advancement in computing and data help the development of a cure and better clinical care?
Okay, so
in computing and data?
I think I'll answer that from clinical care and maybe leave Roger to answer the cure angle. I think it will make a huge difference, but it's no mean feat getting it implemented. And the timescale within which that will happen, I think, is still years, if not a decade or so. I think the barriers around consent and people sharing their data are quite huge, but once we overcome those, the power will be enormous. And I think clinicians are crying out for better IT, better sharing of records, and I think people are too. They're fed up of telling their story over and over again. So I think there's lots of will, and it's just about making that happen, which will be slower than I think we'd like, but hopefully not too far away.
Thanks, Roger.
Well, I would say I think there's two areas where I think this could become very exciting and is already exciting. One, I think, is in the basic science. So there's a lot of new technologies that have come on in the last 10 years where now, for example, you can take individual cells and you can see what they code for in terms of this thing called transcripts, which ultimately lead to proteins. So you can do this in post-mortem brain. You can do it on cells. You can label the cells, and then you can label what each cell is producing. So now you can dissect tissue into lots of different tissue types, and you can work out what each cell is doing and contributing to a disease state. So this is what's happening nowadays in Parkinson's. People are looking at post-mortem brains. They're taking cells out, they're identifying the cells and working out what goes wrong in those cells, and then how those cells speak to each other and cause one cell giving a problem in another. So by looking at these sort of more complicated data sets, looking at networks of cells, I think we're starting to understand now more what goes wrong in Parkinson's and the dialogue between different cells and different parts of the brain. And that's not just in the lab. I think that's also in the clinic. With imaging, we can now look at how things are connected in the brain, how things relate to each other. So I think this is going to change, A, what we think goes wrong in Parkinson's, B, how we can better understand that this isn't a disease of one cell at one place, but a network that goes wrong. And the analogy I always use is, when you look at the London Underground, Parkinson's isn't a problem with Oxford Circus. It's a problem that Oxford Circus may take a major hit like the dopamine cells, but there's probably also problems at Edgware Road. There's probably also problems down at Earl's Court. And those little problems together give you a network that's not working properly. And understanding that will actually help. So if I make Oxford Circus better, that's great. But actually, if I can make Oxford Circus a bit better, Earl's Court and Edgware Road, I'm suddenly going to change everything. But I need to know what bits are actually abnormal in order to fix the network.
Thanks, Roger. A question that a couple of people have asked, which is what criteria are used in stratification or will be used in stratification?
So I would say that at the moment, the way we tend to do it is, I guess there are four major ways in which we do it. One is we do stratification around clinical presentation. So do people have a lot of tremor? Do people not have a lot of tremor? Do people have a lot of problems with gait? So there will be a clinical stratification. This is what patients look like when they present to the clinic. There's a genetic stratification, and these sort of can map onto each other. That's the ultimate goal. So people turn up with Parkinson's and they have a mutation in LRRK2 or a mutation in GBA. So you can stratify people by genetic variants or genetic abnormalities. I think the third way in which you could do it is looking at sort of systemic abnormalities. So there's been interesting work around inflammation and what's in the gut, so the microbiome. So you might stratify people in terms of what does their systemic blood look like from a number of different angles. And then I would say the fourth thing is by doing imaging, and particularly around certain chemicals, you could stratify people around chemical differences in their brain. And ultimately, all these layers may map onto each other. So you may have someone who's got a particular type of Parkinson's clinically. It's associated with this genetic variant. They have this level of information in their blood and this type of microorganism in their gut. And the chemical changes which you look in the brain when you scan them is of this particular type. And so you'd say we have this type of Parkinson's which can be characterized in these four ways. That will then open up opportunities to find out what fundamentally goes wrong in that particular type of Parkinson's and then personalise the treatment to that person.
Thank you very much. I have to say, listening to both of you, really clear, really motivational and really positive. And I can understand you both, which is unusual for me to understand people talking about these subjects. So what gets in the way, though? What's the thing that is getting in the way of these positive perspectives on the world? Maybe Rowan, could you start with you?
Yeah, sure. I think the obvious, so from a health service perspective, from improving health services, what's getting in the way right now? I think the number one thing has to be, a workforce that has been through a lot over the last, 18 months, 2 years. And I think we as a charity need to have a role in building them back up again. They've done a lot for us. So what can we do to support them to get back on track and really start working towards improving services again, having been through what they've just been through? I think I referenced this in my talk. The other barrier, which isn't a barrier, it's just a way of something we have to be aware of and affects how we talk about things. I think, we are living in difficult economic times, and we need to really clearly make the case on behalf of people with Parkinson's for why it's wise to invest in Parkinson's services. What's the case for investing to save? We believe, we know it's there, and we know that, treating early with really proactive therapy from, all angles, physio, OT, speech and language therapy, the right medical care can really help someone live well, continue in their job and continue supporting the economy. So how do we better, I think something for the Excellence Network is how do we better make that case clear so that the politicians are listening to us and really prepared to put their hands in their pockets and pay for better Parkinson's services.
Brilliant. Yeah, I agree. Absolutely. Roger?
Well, the first thing I would say is we need to make sure everyone gets involved with the research. So, when I set up the Parkinson's Clinic in Cambridge, if I'd based took my experiences from that and extrapolated it to Parkinson's in general, then the average age of Parkinson's would be about 48. And the average IQ would be about 134. And that's because the only people who came to my clinic when I set it up were young academics in Cambridge. So if we really want to understand what goes wrong with Parkinson's, we have to get everybody involved and make sure everyone's involved. So the first thing I would say is, we need to be welcoming to everybody, and everyone should, if possible, try and get involved. Secondly, it's obviously financial, as Rowan was saying. If you put enough money into a problem, you can make enormous progress in short periods of time. And obviously, this is competing against other diseases. But if you think how much money went into COVID, 2 years ago, there was no vaccine for it. We're now all vaccinated. So that's 2 years, and that's a lot of money. But you've basically gone a long way with that. And I think the third thing is investing in the long term. So I think one of the problems, in the way we do research is we're often looking for short-term results, which is what you want to be a successful scientist. It's what clinicians want for their patients. It's what patients want for themselves. But sometimes the money's on the longer game. Follow people for longer, learning as we go along. And that sort of iterative, adaptive type of approach, I think, is going to be very useful. And I think if people get into that mindset, that will make a huge difference. So as I probably said before, cancer therapies have changed enormously over the last few years by virtue of the fact that people have learned as they've gone along and added new therapies. So it's that piecemeal approach which I think will give us the rewards.
Thank you. Roger, I'm going to ask you 3 questions in one because they're the 3 most popular ones on the chat box at the moment. Is there work being done to prevent Parkinson's starting, so we don't need interventions at all? Can we create a drug that doesn't have side effects, or is it automatic that you have to have side effects if you're going to have a powerful drug? And can stem cell transplantation stop Parkinson's disease, and could they be strengthened to be successful?
Yeah, okay. So this is someone obviously checking my cognitive state, whether I can remember 3 questions. So I'll start with the last one and work back. So stem cells will never cure people with Parkinson's disease because they're just simply replacing something that's missing. So curing is stopping the disease process. That's not to say they couldn't be very effective. So our ambition is that we can produce dopamine cells which are healthy and young and will survive for half a century, and that will do enough for people. You can engineer them so they don't have alpha-synuclein, which was where we began this question and answers, so they couldn't get pathology themselves. So I think stem cells offer a huge transformation in the symptomatic treatment of Parkinson's disease, especially around dopamine, but would never be curative. Secondly, I think the idea of preventing Parkinson's disease is very attractive. And there are two challenges with that. One is obviously screening. So do we have an accurate screening process by which we can pick up Parkinson's disease with absolute reliability? And we don't have that at the moment. We have measures which are suggestive that you will go on to get it. But also there's no point screening people if you don't have a therapy that stops it. Why would you want to know you're going to get something if you can't do anything about it? So I think that then speaks to the second question about drugs without side effects. I think if you have any drug without a side effect, it's probably not a very effective drug, because I think any drug is going to have some fairly major effect on targeting some aspect of the disease process, and that will, I think, like all drugs, have side effects. As I've said, I think the future will be that we will have reliable screening techniques. We will give people polypills, so each drug in itself is not particularly toxic at the dose we give, but the combination will actually slow down the disease. That will hopefully slow it down sufficiently that when you present, you can have a stem cell transplant, and then we can all go home.
You successfully got all three questions. Well done. So, quick question for you, Rowan. It would be amazing if we could have a credit card type card that we could integrate all our medical records, so we don't have to repeat them, and we can take that with us. Do you think that's a possibility in the near future?
Definitely, I do. I think it's a great idea. I think lots of people, it's been talked of for many years. I think we've learned a lot from the development of the COVID app, for example. I mean, I know that hasn't been a perfect rollout, but, we've learned how to get records onto most people's phones so that they can use them in different ways. I think I don't think the barriers are huge. I just think it's a matter of kind of working through them one by one. And I do think there is a lot of will for this sort of development, and it would, again, it comes back to what I was saying about spending wisely. I mean, think of all the time that people spend, not just the person's time, but clinicians' time, listening to the same story in a different way over and over again. If we added all of that up, and I don't know if anyone's done the sum, that is an enormous amount of money. And if we could redirect that into smarter ways of working, then I think, it may even be cost neutral or cost saving. So I think we need to be clever about how we think about implementing these sorts of developments. And I do believe they're not far off. Not this year, not next year, but may hopefully in the next few years.
And this is a really difficult question for both of you. So just on the same theme, what sci-fi technology do you think could you see being used in Parkinson's in the not too distant future?
Well, if I would think that what we hopefully can do is deliver things peripherally, which selectively get into the brain and target the areas where the pathology exists. So targeted therapy, things given in the circulation, get across the blood-brain barrier and track and find the cells that are abnormal and correct them. That's the real sort of sci-fi, I think.
That's a great answer. But I think something that's not that sci-fi, because it's not far off, but there's all sorts of innovations around cueing, for example, glasses that produce a sort of virtual reality visual cue for helping people with freezing. I don't think they're far off being sort of spread out, and I don't think they're far off looking like a normal pair of glasses. So who knows? Let's see. But and we don't know which ones will take off, but I think yeah, they're close.
Good answer. Here's one that I personally find really interesting. The wearing off of the effect of medication has a big impact on our everyday quality of life. Should more attention be given to developing medication that keeps us at a more consistent level all the time?
I would say yes, and I think that's I guess is one of the hopes for the stem cell dopamine therapies, is they will just be producing dopamine all the time, so you won't get these fluctuations. And I think you're absolutely right. If we can get therapies that can give consistent levels of dopamine, so you don't have these complications of too much or too little, that would be perfect. And we're close to that.
How close do you think you are to that?
Well, I mean, there are therapies out there already, like duodopa and such like, which is obviously quite invasive, but there are these new therapies where you put dopamine under the sort of skin or into the skin, and they're all looking very promising.
We're just getting going with this, I feel, but we've only got time for one question. I'll leave it to you, Roger. Any thoughts on gene editing or gene silencing?
I think going for genes is very attractive. Parkinson's is a little harder because there's no obvious gene to go for unless you try and do something with the synuclein gene. The real challenge with gene silencing, gene targeting, is getting it targeting the right gene in the right cell and it lasts without doing any damage. Because obviously if you target the wrong gene and do the wrong thing, you get cancers. So that's the real challenge. But I think it's a very exciting area.
Brilliant. Thank you very much. And thank you, Roger and Rowan, for such a both positive but also really clear set of explanations and perspectives. So with that, I'm delighted to hand over to Caroline Russell, the new CEO of Parkinson's UK, to wrap up both today and the conference as a whole. Caroline.
Thank you, Gary. And good afternoon, everyone. As Gary said, I'm Caroline Russell, the new Chief Executive here at Parkinson's UK. And I'm really delighted to be here to close this wonderful event and thank the amazing team of people who have made it all possible. For me, as someone who is still fairly new, 51 days in to Parkinson's and the community, it's been a phenomenal opportunity to learn about research and the condition itself from researchers, health professionals, and most importantly, from you, the community living with Parkinson's. I want to say a very big thank you to every single person who's been involved in making the conference happen for their time, energy, and passion. In particular, I want to pay tribute to the team behind the scenes. As you may be aware, a team of volunteers, all living with Parkinson's, have led the planning for every element of the conference, from deciding the theme, improving lives through research, to designing the individual sessions and event platform. This group has been working tirelessly on ParkOn since January. I'm sure you'll agree with me that their dedication has really made this conference special, and the fact that this event has been created for people living with Parkinson's by people living with Parkinson's has shone through in every aspect. A special thank you to Laurel, Carol, Andrew, Clive, Neil, David, and Lizzie for all their hard work, ideas, and energy, which has made this event so incredible. For me personally, I've really enjoyed the events. And yesterday, I got to know what the word queuing was, which Rowan has used again today. So thank you. And this team of volunteers has been supported throughout the development of the conference by our wonderful staff team here at Parkinson's UK, and in particular by Liz Nash, our Research Support Network Manager. Liz, thank you. A couple of further thank yous to Event Concept, the agency we've worked with to host this event. It really has been seamless, and we really appreciate all your hard work behind the scenes to make it that way. And to our sponsors and supporters, Stroll, Charcoal, Nutrotech, the National Garden Scheme, and the J. McDonald Menzies Charitable Trust, who financially supported the event. We are extremely grateful for your support. But the final and most important thank you goes to all of you for joining us. Thank you for taking the time to come and hear more about research and all the ways in which it is driving things forward to improve the lives of everyone living with Parkinson's. Without people who care and who want to take action, all the research that you've heard about over the past few days simply could not happen. Whether this was your first time attending an event about research or you're a seasoned volunteer, we hope you found something during the conference that has inspired you to get involved or to stay involved in research, whether it's as a volunteer, a participant, a fundraiser, or a campaigner. Every person's contributions matters and makes a difference as we continue to strive for better treatments and a cure together. We will be sending out a very short survey by email, and we'd be so grateful if you could fill it in to share your thoughts on ParkOn. Your feedback is critical to helping us to continue to improve the events we do. So please do look out in your inboxes tomorrow. Well, I think that's it from me. Thank you again so much for being part of Parkon, and I hope to see you very soon.